Breast augmentation is a very complex concept that can be reduced to several very simple principles. Effectively, breast volume has either been lost through atrophy or involution, or the tissue was never there in the first place. If we're talking about a mommy makeover, more often than not, the breast tissue has been consumed with multiple years of breastfeeding, and the tissue has become atrophied. Patients will present and say, I want to be back to the body that I had before I had a baby, and I liked the size that my breasts were when I was nursing. So the first thing we have to do is understand the basic anatomy, and then understand and help patients be educated as to what their goals really are, and then what the recovery process is going to look like. So for this particular patient here she is before, here she is at about a week after surgery, and here she is at about 2 or 3 months after surgery. And so the important thing that I want to point out is there are two main differences in terms of where to put the implant when it comes to breast augmentation. The implant can either go in front of the muscle or behind the muscle. And so the pectoralis muscle, or your chest muscle, is effectively coming down here, and everything in front of that is the breast parenchyma fat area coming all the way down here. So the implant can either go in front of the muscle or behind the muscle. If it were to go behind the muscle, you make your inframammary fold incision here, and then you dissect up and you put the implant behind the muscle. That's called retropectoral implant placement. There are many benefits to it. Some people are adamant that that's the way it should go. Others are more open-minded. I like to listen to the patients and try and understand what their desires are before coming to a hard conclusion. Some of the things that can be more frustrating if you go more superficial in front of the muscle, and it's very simple to understand, is that if you're now putting the implant in front of the muscle, it might be a little bit more palpable at the top, especially if you're placing a saline implant, which tends to have a little bit more rippling. And so that's why if patients tend to be thinking about going more superficial or in the pre-pectoral plane, they would probably consider or be counseled to consider a silicone implant. Let's talk about what the patient looks like at 1 week after surgery. And in this particular case, we'll make the assumption that this patient's implants have been placed in front of the muscle. So here is the muscle coming down like such, and then here is the implant. And even though these implants, if we're talking silicone, are form stable and can have a lot of shape that they hold, they'll tend to create more of a teardrop shape when they sit in the breast. Here's all the fat underneath here, and again, the incision to get to this location was made through the inframammary fold. The dissection was performed here. This is how the implants sit in the early phase. So here we have the patient at about 3 months afterwards, and you can see that now the implant has achieved that fullness down into the pocket and rounded out that shape and that beautiful contour at the lower pole of the breast. That's the transition between placement 1 week and about 3 months. If it was retropectoral, then the implant would be back behind the muscle. And you can see why there may be some benefits to it if the muscle is up on top of the implant, if the implant was one that had rippling, such as a saline implant. But with the silicone, it's got such a nice shape and contour, it doesn't ripple like that. But these are differences that patients need to consider with their surgeon as they're making the determination as to whether or not they want saline or silicone implants. Next, we're going to pivot and talk about the medial cleavage and what the difference between placing an implant in front of the muscle or behind the muscle can mean. If a patient is very motivated that medial cleavage is one of their top priorities, then there's a basic understanding of anatomy that needs to be discussed here. And if the patient is highly motivated to have the implant such that there's much more medial cleavage, you need to understand that it's going to need to sit on top or in front of the pectoralis muscle, because if it's going behind, the implant is here, it is limited because of where this muscle attaches to the chest wall, to the sternum. And because you can't release that muscle entirely, because it would just retract and then you'd get all kinds of weird breast deformities and breast animation. So you need to leave that attached. So you could understand that the implant would have a limitation to how far it could be placed medially if you wanted to have that medial cleavage. Now imagine on this side that the implant was placed, again, make the incision come up. Now the implant can be placed much more medially, and on top of that, it's able to affect the breast mound. So it doesn't go entirely beyond the muscles. It sits just at the medial aspect of the muscles so that you're creating beautiful cleavage to the medial aspect. But you can see how if it's sitting on top of the muscles, it's not being constricted by those muscles and flattened. And so much more medial cleavage, whereas here, this is the midline. This implant is sitting much more laterally. This implant is sitting much more medially, and that's because the muscle here is impeding its ability to come closer, whereas here, the muscle is underneath. So this is called prepectoral placement. This is retropectoral placement. In this particular patient here, she had her implants placed in the prepectoral space, and so she was able to deliver and generate that much more medial cleavage that she was looking for to give her breasts much more cleavage and much more mobility. And honestly, it doesn't matter in terms of the overall performance of her implants in her lifetime. What it matters is the pocket dissection at the time of surgery for placing these implants. And so this is the difference between prepectoral, retropectoral implants, and in her particular case, these implants were placed in the retropectoral space. So that concludes the breast augmentation portion of the mommy makeover, or obviously breast augmentation can be performed on its own. All right, thank you so much.